Hi, welcome to UCSF Family and Community Medicine Grand Rounds. We are very excited to have you here today. We have a terrific presentation. And just as a reminder before we start, I wanted to let you know that this session is being recorded and has closed caption as well. If you would like to see this session recorded later or any previous sessions that you've missed, you can look on the UCSF Family and Community Medicine website, and we have pre-recorded sessions there, and this one will be posted probably in a couple of days. I forgot to introduce myself. My name is Margot Venner. I'm the Vice Chair for Education here in Family and Community Medicine, and I am really excited to have the presentation that you're going to hear today. Our presenters really would like you to be able to engage with them. So if you have thoughts or comments or questions, please use the Q&A box to answer your questions, and we'll either respond to them digitally or let our presenters answer live. And also, just as a reminder, we value your feedback. So there will be an evaluation for you to fill out if you want to coming to you digitally as well. And as always, if you have suggestions for grand rounds, please get in touch with me. So our speakers today are Dr. Shira Shavit and Mr. Joe Calderon. And the topic that they're going to be talking about is related to transforming healthcare systems through hiring and partnership with communities impacted by incarceration. Decades-long policies of mass incarceration and criminalization of mental illness and substance use disorder have resulted in significant health disparities for individuals and communities who are impacted by the criminal legal system. While primary healthcare systems can play an important role in addressing these disparities, studies show that people face stigma and discrimination in healthcare systems because of their incarceration history. The Transitions Clinic Network works with primary care clinics to transform their systems to improve health equity for communities impacted by criminal legal systems. Clinics participating in the Transitions Clinic Network hire community health workers with lived experience of incarceration and dismantling systems that have historically prevented people with criminal records from accessing employment in the healthcare fields. Our presenters today are Dr. Shira Shavit, who is a clinical professor of family and community medicine at UCSF and also executive director and co-founder of the Transitions Clinic Network, and Mr. Joe Calderon, who is a senior community health worker of the Transitions Clinic Network. Both of them bring a tremendous amount of experience and passion to this field, and I am really excited to hear their presentation. So with no further ado, I will hand it over. Thanks.
Thank you, Margot. We're just really excited to be here with everyone today and really encourage lots of questions. It's always a little bit harder in a webinar because I can't see your questions as easily, but we'll make sure we leave lots of time at the end for conversation and discussion. So with that, here we go. Please let me know if you can't see my screen for some reason or can't hear me at all during the presentation. So hi, I'm Shira Shavit. I'm a family physician and I trained here at UCSF in the Department of Family and Community Medicine. And just a little bit about me, actually, I came to this work during my residency. I was caring for women at the Family Health Center who were pregnant and were actually incarcerated over at a federal penitentiary in Dublin. And Hallie Hammer, who was my mentor and attending at the time, was helping this MINT program where women could come out of prison to the community and deliver their children. And that was really my first interaction in working with patients who were incarcerated and hearing their stories. And it was kind of these very difficult stories to hear about the poor care that these women were receiving inside, and also the real challenges they faced in the community that really drew me to this work. And I followed my patients into the criminal justice system, working at both Alameda County Jail and at San Quentin, and then coming back, following them again back out into the community. And so have really been working with patients impacted by the system of mass incarceration since I was a resident. So really looking forward to sharing with you some of the work that we're doing here in San Francisco and nationally. As you heard, I direct the Transitions Clinic Network, which is a national organization that supports health systems in caring for communities impacted by mass incarceration. And all of the clinics that we work with are dedicated to hiring community health workers with lived experience of incarceration. And we all work together in addition to implementing these programs, and we engage in research and policy work together. So today I'm going to be talking about the Transitions Clinic Network, what the work looks like. You'll be hearing from both Joe and I, and about a unique feature of our work, which is hiring community health workers who have histories of criminal convictions, and kind of looking at this work through the lens of an anti-racist strategy in our healthcare systems. But before we kind of delve into all of that, I do think it's important to talk a little bit about the context of mass incarceration and kind of what has led us to doing this work. So as many of you know, mass incarceration is a series of policies and laws that have led to a over 500 increase of number of people incarcerated in our country. So this is over the last 4 decades that has driven so many people into the jail and prison system. Today, 2.2 million people are in prison or jail. And when we think about people impacted by mass incarceration, it's not just individuals who are actually behind bars, it's also people who are on community supervision. And when I say that, I mean probation and parole. There's 4.7 million people who are also part of what we call the criminal legal system. And there are also far-reaching ways that this system of mass incarceration have impacted individuals and communities, which I'm going to kind of delve into a little bit later. So really the reach of this is far beyond those numbers. And so I think it's important, though, also to recognize that this system of mass incarceration has had devastating impacts on communities, in particular, Black and Brown communities in our country. And we know that Black and Brown people are disproportionately arrested and convicted. And as a result, when we look at our system of incarceration, Black people are 6 times more likely to be incarcerated than whites, and Latinx individuals 2.5 times more likely to be incarcerated. So this really is, one example of systemic racism in our country. And unfortunately, when we think about people who are in these systems, we know that there's also tremendous health disparities, that people who are incarcerated have higher rates of mental health conditions, substance use disorder, as well as chronic physical conditions like hypertension, asthma, cancer, and other infectious diseases like hepatitis C and HIV. Also, the system of incarceration itself, being locked up, can lead to worsening health. I think this picture is a very clear picture. In the context of COVID, before vaccines, people were 5 times more likely to get COVID in the incarcerated setting. Other ways that setting has had negative impacts on people's health, in particular mental health, and thinking about the trauma that people experience in post-traumatic stress disorder. So that could be a whole nother grand rounds that we don't have time to talk about today, but I think it's really important that when we think about the communities we serve, we understand these disparities in health that we see. Now, 95% of people who leave, 95% of people who are incarcerated will leave that system and come to the community. And there's also very high risks related to health upon release. And so there have been numerous studies that have shown that when people leave the system of incarceration, their health worsens. They're more likely to end up in the emergency department, and they're much more likely to be hospitalized. Additionally, a seminal study that was done in 2007 showed that individuals, a large number of people leaving the state prison system in Washington state, really kind of demonstrated that risk of death in the first 2 weeks post-release. And what that study showed that people were 12 times more likely to die in the first 2 weeks post-incarceration. And the reasons were drug overdose, cardiovascular disease, homicide, suicide, and cancer. And so the large majority of those are medical conditions that we treat in our primary care setting. So I think for me, this was when I read that study, a real light bulb went off and really helped me understand that the health system in the community actually plays a really important role in mitigating some of these health disparities for individuals who are coming out of prison. Yet, even in spite of that and the health system being able to play a role in caring for people, there's a lot of barriers for people to engage in health systems post-incarceration. So for instance, there's a major disruption in continuity of care. People are going from a carceral system to the community health system. They may not have insurance. There may be a disruption in their coverage. There's very little in the way of discharge planning or connections to care in the community, and they're often given a very short supply of medications, usually no more than 30 days. And when people come out, they have a lot of competing priorities. They have a lot of needs. You can imagine you're incarcerated and you come back to the community, all of your social determinants of health are insecure: housing, employment, access to food, education, et cetera. And people who are incarcerated in this country or have histories of criminal convictions actually face additional barriers, which we call the collateral consequences of incarceration, which makes it even more difficult for them to meet their basic needs. It's difficult for individuals to navigate complex systems. Sometimes services are unavailable or they're not tailored to the needs of people coming home. And very importantly, people do experience discrimination and stigma in the health system, leading to mistrust and naturally a lack of desire to utilize those services. So as we know, people who are impacted by the system of mass incarceration are disproportionately the Black and Brown community, which are the same communities that have experienced discrimination in healthcare systems. And many studies have shown that has led to worsening health outcome for these populations. Well, in our healthcare setting, we do know that people also experience discrimination based on their history of criminal legal involvement. In one study that surveyed individuals returning from incarceration, 42% noted that they experienced discrimination based on their criminal legal involvement in the health setting. And that also, we know similarly, people with criminal legal involvement that experience discrimination have worse health outcomes, like increased ED utilization and increased odds of having self-reported fair or poor health. And then lastly, this study, which came out in 2019, which was published by our colleagues in Ontario, Canada, where there's universal healthcare coverage, demonstrated additional barriers that people have to accessing care in the community. And this study always makes me really pause, but essentially the study was looking at when people call primary care clinics asking for an appointment, if they were comparing people who did not say they had a history of criminal legal involvement versus those who did. And the people who said they did not have criminal legal involvement were twice as likely to get appointments in the primary care setting. So this is in a system where everyone has coverage, and yet having that history of criminal legal involvement made it so that people could not even get appointments in the clinic. So kind of knowing that there's this high burden of disease, a real need to a very imminent need, this high risk of death upon release, people need to get into services in community health systems, yet face tremendous barriers. And so, in thinking about what can health systems do to transform to better meet the needs of these individuals, two UCSF residents posed this question to say, how can we transform our systems? And this was Emily Wong and Clemens Hong, who are both internal medicine residents, who ended up convening a group of stakeholders that included City College of San Francisco, as well as legal services for prisoners with children. And, really with the intent to say, how can health systems not reinforce the punitive aspects of the criminal legal system? How can we embrace and support people coming home? And how can we transform our services to really meet all of the needs of people who are coming out of incarceration? And so through this process, we were able to define what some of the engagement strategies would be for really addressing the health needs of people who have criminal legal involvement. And I kind of think one of the, I'm not going to go over all of these, but there's a couple of really key points here that have really been kind of our guiding beacons in this work moving forward. Primarily that it's really critical to include individuals and communities impacted by the system in the design, implementation, and evaluation of programs. So while that sounds obvious, I think it's important to recognize that when people are incarcerated, they're given a name and not a number. They lose a lot of their autonomy and often are not at the table for conversations around what systems should look like and what their needs Also importantly was that it was really important to take this broad perspective on health and well-being, not just focusing on physical health, but also behavioral health and all of the social determinants of health. And that programs should be integrated into communities, not separate. They didn't want to be treated differently because of their history of incarceration. And that very importantly, health systems were not inadvertently replicating the criminal legal system. So, not perpetuating discrimination and ensuring that they weren't replicating those systems in any way. So this is how the Transitions Clinic program was born. And sort of through those values, the program took shape really with this idea of working with existing primary care clinics to transform what they do, primarily by hiring community health workers with lived experience of incarceration into the primary care team. So they are working alongside doctors and nurses, mental health providers, to kind of open the doors of the clinic to kind of be more contiguous with other systems, both the criminal legal system, as well as all of the community-based organizations that support individuals in reentry. So really kind of transforming what we do in our health system. So because the community health workers are just so critical to this work, I'm going to now pass this over to Joe Calderon, who is going to share with you more about the role of the community health workers in our programs.
Thanks, Shura. I can resonate sadly with much of what we just reviewed in experience and working with returning community members. I don't know how many of you or any of you can relate, but how many of you have had your humanity taken from you by people, policy, or systems? I'm Joe Calderon, and I'm a returning community member. And I'm many things, but I'm not my record. Just like none of you are defined by the worst thing you've ever done, then nor should we be defined by our records. While incarcerated, I watched friends die of treatable diseases. You know, a system that said, or we're led to believe, to keep our society safe, lets people die. While accountable and insightful to my bad decisions and how I hurt my community, as I addressed my own traumas, I started to see issues and policies from a macro level that were racist, biased, and traumatizing to my community. I paroled wanting to be a part of the solution, and as part of the solution, I became a TCN CHW. Slide, please. As a CHW, I, like the rest of the TCN CHWs, use our experience professionally to bridge the gaps for people who are rightfully untrusting the systems. My bridge was Juanita Alvarado, meeting her at a pro meeting, and finding out that she had a history of incarceration was inspirational, because I also found myself wanting to help my community. Slide, please. You know, we use these relationships we build to keep people in care while teaching the patients to navigate the medical and social field based on their needs. Some of our patients tell us things they won't even tell the doctor. And for us to then in turn advocate for the doctor. We're interpreters for our community to the clinic and from the clinic to our community. You know, at that point, we advocate. Slide. Doctors know how to treat chronic conditions. Let me repeat that. Doctors know how to treat chronic conditions. CHWs knows what's in the fridge. So CHWs have a pulse on what's going on into the community and actually have access to resources in those communities. The CHWs network in many, many cases can be the lifeline for patients. Slide, please. And when we think about those relationships not only empower our community, not only empower our patients, but they also empower our community. Countless patients have followed my footsteps, and now they're CHWs themselves. Slide, please. Advocacy. My path has been one from trauma to medicine to advocacy. Like many of our CHWs, the more we learn about systems, the better we understand the problem and our place in the solution moving forward towards health equity. Thank you. Slide, please.
Thanks, Joe. I just wanted to, before we kind of keep going with the presentation, acknowledge I am seeing your questions and your questions as we go. And so some of these I think are to come. And if we don't get to them, we'll make sure we answer them at the end. So thank you so much. Keep them coming. We love questions. So Joe told you about the role of the community health worker, how critical that lived experience is to really working with the patients. But the question is, while that was what the community defined it was as it being what was needed to really move the needle on caring for these patients, the question is, does it work? And so I'm going to share with you 2 studies that we were able to do to evaluate our model. This first one is a randomized controlled trial that we did here in San Francisco. Emily Wong was the lead author on this study. And this was, as I mentioned, an RCT looking at 200 individuals returning from state prison to San Francisco. People were engaged through the community health worker into our clinic at Southeast Health Center, and then either randomized to stay with us or to continue in usual care in the San Francisco safety network. And what we found is that individuals who stayed in care with us had 50% fewer emergency department visits in the first 12 months post-release. So this study showed that the effectiveness and high rates of primary care engagement by utilizing community health workers with lived experience, as well as the reduction in emergency department utilization. The next study that I want to share with you was a propensity match study that we did in Connecticut, looking at our program in New Haven, Connecticut. And what we did is we took a propensity match control of individuals leaving Connecticut's shared system of jail and prison and matched them to TCN patients. And these were, the match control was in a different city in Hartford as compared to our TCN patients in New Haven. And this study did show also a reduction in health utilization, this time in preventable hospitalizations. But the piece I really want to highlight is that it also showed that patients in our program had fewer probation and parole violations, and as a result, spent 25 days fewer in jail at 12 months. So had fewer future contacts with the criminal justice system. And so really important in thinking about, we know that there's significant health impacts from incarceration and really trying to prevent people from that future contact. So kind of pivoting a little bit, now you know about our model, a little bit of our outcomes. I want to focus in more on this aspect of hiring in healthcare and kind of framing this as an anti-racist approach to caring for patients and transforming our health systems. And so we started this work in San Francisco in 2006, and we have since expanded it to 48 different primary care sites in 14 states in Puerto Rico. And these are all health systems that are in communities disproportionately impacted by mass incarceration and really dedicated to improving what they do for the community. And I just want to note that in California, we have 21 programs, and some of them I know may be on this call thinking about Lifelong Medical Center in Alameda, Contra Costa County. We work with 2 of the sites there through the county, and also Sutter, Santa Rosa. So acknowledge that many of our colleagues through UCSF are doing this work. So really appreciative of these wonderful partners that we have committed to working with communities impacted by incarceration. So let's talk about hiring and the impact of mass incarceration on hiring. So when people are incarcerated, we talked about how people often end up in prison or jail when they're subject to the system of mass incarceration. They come out of that system or they're on probation and parole. And then what people face are what we call collateral consequences of incarceration. These are laws or policies in the US that continue to effectively punish people even after they've done their time in the system. And there are over 44,000 documented collateral consequences of incarceration that impact people across all aspects of their lives in trying to move forward with their lives, reintegrate into the community, and meet their basic needs. So things like access to food stamps or other TANF type benefits. Also, it could be access to education, secondary education, or getting government grants to support education. Other things are things like being able to vote or sit on a jury. It could impact housing. And then I think really importantly, what we do know know is that the large majority of these collateral consequences impact employment. So both directly through employment, through getting business licenses, as well as other occupational and professional licenses. So what does this economic impact really look like for people who have come in contact with the criminal legal system and have a criminal record? So what we know is that $78 to $87 billion in GDP is lost every year because people with felony convictions are unemployed. If we look at this beyond the felony convictions, because this is not just for people who have serious crimes, this also includes people with misdemeanors, that number grows to 317 billion. And that this has really far-reaching implications because it's not just during the time when people are incarcerated, it's after the fact, right? If you have a criminal record, that goes with you for a very long time, right? And so now in the US, 1 in 3 people have a criminal record. That's 77 million people in our country. And that 50% of children in the US have a parent, at least one parent with a criminal record. And as a result of mass incarceration, we have tremendous poverty in our country. So if we had not had these 4 decades of these policies and this rise in people impacted by these systems, the US poverty rate would have dropped by 20%. So like other policies related to mass incarceration, what we see are also racial disparities, particularly around hiring and unemployment. And so on this slide, what you can see is on the left side, the disparities that exist at baseline between Black men and Black women and white men and women in the US general population. But then when you look at individuals who are formerly incarcerated, those disparities are even more magnified. And you can see that Black men and Black women, really kind of that distinction for people who are formerly incarcerated, but that also, you know, these collateral consequences impact everyone who is in the system. So I think one of kind of the important pieces here, though, is in thinking about that is sort of making this link, and that, you know, Michelle Alexander, who's a legal scholar and wrote The New Jim Crow, really helps link this to this idea of legalized discrimination in our country, thinking back to Jim Crow laws. And she really likens these policies to a new Jim Crow. And what she says is, once a person is labeled a felon, he or she is ushered into a parallel universe in which discrimination, stigma, and exclusion are perfectly legal, and privileges of citizenship, such as voting and jury service, are off limits. So that's kind of a lot, you know, to take in, and thinking about, well, what's the role in the health system? Is there something that we can do to help dismantle some of these systems? And so I do think we have a unique opportunity, but we also have unique challenges in our system. So being in the health system, we have a lot of patients who are sick and vulnerable. And so that poses a unique challenge. And I think there's a lot of fears within our system that employees who have a history of a record may not be good employees. They may have high turnover. They may not be hardworking. And the biggest fear, right, is that they will commit crimes, putting an employer, obviously hurting a patient, but also putting an employer at legal risk. And I kind of want to touch on this just for a second, because in one of the sites that we worked with, which is in the South, we had wonderful colleagues there that had really kind of done their due diligence and working all the way up their system, all the way to the CEO of the hospital to ensure that hiring someone with a record would not be an issue. And yet when it came to the head of HR, there was a lot of concerns about the safety of this issue. And so we asked the head of HR, you know, tell us more about what your concerns are and give us a scenario that you could imagine could be problematic. And so, you know, she kind of put out this idea of, what if the community health worker was transporting a patient to an appointment and then started choking the patient? So, you know, I think when we heard this, it really kind of really illuminated how deep a lot of the kind of stigma that people faces, the discrimination, sort of this belief that because someone had harmed someone in the past, that it was a sure thing that they would do it again. And I think the reality is that the data does not bear out, and that this is really a lot of our own implicit bias and discrimination against people who have been impacted by this system. So the reality is that people, are not necessarily more likely to commit crimes because they have in the past. So for instance, there's a study that shows that there's no difference in the likelihood that someone will, with an assault record, will commit another crime after 4.3 years. So, the longer time has gone by, the less likely someone is to have a repeat offense. And I think this is an important piece to recognize and try to kind of just debunk some of these myths. There are other studies that have shown that people who have histories of felonies in the military, for instance, were promoted faster. They were no more likely to be discharged. And a kind of another really key study is looking at 500 employees who had histories of criminal records that were hired by Johns Hopkins. And so this is a really interesting study to look at because Johns Hopkins, which is in East Baltimore, really wanted to serve as an anchor institution, hire individuals from their own community, and found that many of the people surrounding the hospital had been impacted by mass incarceration, had histories of criminal records. And so they actually implemented a special program to ensure that those records weren't acting as barriers to employment. And so they hired 500 people over 5 years and found that they were no more likely to leave their jobs, and that when they looked at individuals with more serious criminal records that were felony convictions, there was a subset of 79 patients, only one of those people was dismissed for cause. So I think it's also important to recognize that there are many ways that people can be excluded from employment because of their records, that these barriers are cumulative. And so I just kind of want to run through this briefly of just kind of giving some examples. So for instance, one of the sites we worked with in Minnesota has an ability to bill Medicaid for community health worker services, yet the community health workers have to go through a state-sponsored training. In that training required a background check to complete the training. So community health workers with lived experience were facing barriers at that level. While most community health workers are not licensed, they often are increasingly, we're seeing certification in states. And Ohio is a good example of that. If a community health worker doesn't pass a background check, they're unable to be certified as a state community health worker in Ohio. And then also, we often see that there's barriers kind of at the state health agency level. So we've worked with Wisconsin, which actually has state laws that list specific convictions that are excluded for hiring in the healthcare sector. So we were able to hire and work with that site, but it really was very limited to who could get that job that had a history of prior incarceration. So what about our program? So we're doing something kind of unique. I think when we think back about this kind of cascade, this kind of also shows where a lot of the interventions can be to try to make it easier for people to be hired. And so when we think about reforms in this system, these are kind of all of the places that we see reforms in. One example is that is in California, we have fair chance hiring. So it's the ban the box, right? So employers kind of, when you get to this lower level, employers are not allowed to ask about prior records or criminal convictions until after they've vetted the person and offered them conditional employment. So that's one example of how some of these things can be mitigated. Yet in our work that we're doing, we have a little bit of a different approach, because that whole cascade is really and kind of reforms to that cascade are intended to make it easier for people to move through for really any type of job. In our work, not only do we want to hire people who have lived experience of incarceration, but we want to be very intentional about it. And so our approach is really different. We're actually working with health systems and we're putting out job descriptions that say, we want you to have this history of incarceration. This is actually a required qualification for the job. And so in doing this, it really does require some training and technical assistance around the best practices in hiring. when we work with sites, we work with them across the whole spectrum of hiring, starting from drafting the job description all the way through to training new staff and mentoring them in their positions as they work to ensure success in those positions. And so to kind of touch on a few of these points, I think the training HR piece is a major part of what we do. As you heard, HR tends to be kind of, I think, the point in the system where there's the most concern around legal risk in hiring. And so, this is really where our expertise, and in particular, our expertise of the community health workers really comes in to help kind of move this along. And so, Joe, can you talk a little bit about what you might share with someone in HR when they're, when they hear from their program lead that they want to hire somebody who has a history of a felony conviction?
The first thing I would just throw out there is, letting criminal records bias hiring decisions will not get you the best candidate for the job. And you might get the better resourced person, but they'll lack the experience needed for the position to create those relationships that keep people in care, at least working with my community in general, but I can see that along many, many communities that are being served. But I would also tell or ask, the HR people out there to think about this. I'm not your ideal hire. I spent close to 20 years in prison. I went to prison for second-degree murder. Would my resume cross your desk? Or would we hear the sound of the shredder? I don't know. But today I do have an ask. I challenge you to challenge those stereotypes, because what stereotypes don't tell you is that people with long terms for violence have the lowest recidivism. That those of us that have done long terms now understand that what we have taken from the community, what we have taken from society. I'm not my record, I'm a living amends to my community. And on that note, I want to say two things. One, you could not even imagine the stress relief going to a job interview where they said we're actually having a felony record was a prerequisite. One. And two, a professional colleague of mine often says those closest to the problem are closest to the solution, but lack the resources to the problem. We're at a very, very interesting stage in California. And I think we have a lot of opportunities to address these stereotypes and start hiring the people that are best for the position, not based on what they did 20 or 30 years ago, but based on who's sitting in front of you today. Thank you.
Thank you, Joe. And I think, this is kind of really highlights, kind of the perspective and approach, and that because we're working with patients who are leaving prison and jail, we want community health workers who have been through that whole spectrum of incarceration. And so we're often looking for people who have felony convictions, who have done significant time in the prison system. So really kind of working at that level to, one, very overtly hire people who have this experience. We're looking for outcomes of people who have those more serious records. We work very closely also kind of in recruiting and getting the right people at the table. I think there was a question in the Q&A about that. And, this really requires partnerships with community-based organizations. It requires partnerships across communities impacted by mass incarceration. Joe has an incredible network that anytime there's a job available in California that we put out and kind of through word of mouth, gets to many people, and then working with local CBOs that know these individuals, health systems are much more likely to hire someone who's known or vetted through our organization or another organization. So, we also help systems kind of avoid common pitfalls, like doing things like asking candidates to list their criminal history before running the background check, because invariably there could be some discrepancy there. People may not know exactly what's on their background check. They may not know the language that's being used. And because of the implicit bias in our system, what happens is then they're seen as lying and not being truthful because of that mismatch. So we always recommend against that, for instance. So these are just some examples of ways we support health systems in finding the right candidates and hiring them. And as a result, we've been able to hire many people with these histories of incarceration. All of our programs are committed to hiring people with prior incarceration histories. Right now, we have 59 community health workers employed. The large majority are racial and ethnic minorities, 63% are Black African American. And a subset of those were at a meeting a couple of years ago here in San Francisco, and we were able to survey them about their criminal history. And we found that 60% had a history of a violent crime, with 21% having a murder or homicide in their past, and 39% with assault or battery. So this is really kind of what we're hoping for in really addressing these systemic barriers that people face in hiring. So we're kind of getting close to the end of time, so I'm going to kind of blow through this. I think it's just important to recognize, I just want to acknowledge the positive economic benefit, not just to individuals, but to their families, to our society, and also reducing criminal justice expenditures by having people hired in our health system. So many positive economic benefits of this work. And so kind of in wrapping up, as Joe mentioned, there's just a lot of opportunity here in California. We have a lot of hiring reforms like the Fair Chance Act and AB 2138. We have shortages around healthcare staff, and then we have opportunities for more paid positions that address people's needs coming out of incarceration, like the CalAIM waiver that will have a focus on reentry. So our next state waiver will focus on caring for people coming out of incarceration. There's a state plan amendment that's in the works to pay community health workers for preventative services, and then a development of a peer support specialist for people with behavioral health conditions, many of which are coming out of systems of incarceration. So there's a lot of opportunities to explicitly hire people, have this known history of incarceration, but there's also other opportunities within the health system to increase hiring for people who have this criminal legal involvement. And just briefly, thinking about systems that are interested in anti-racist initiatives or anchor institution efforts, like I mentioned with Johns Hopkins. And I think one of the kind of positive benefits we've seen from our work is that as systems get comfortable hiring through their work with us, they often expand that hiring to other positions, right? And one of the clinics was telling us, we've now learned how to navigate this process. We've actually started hiring more people with criminal legal involvement in our clinic and other positions that are not necessarily community health workers. So in summary, hiring community health workers with histories of incarceration improves health equity. It reduces future contact with the criminal legal system. Health systems can address structural racism through hiring people with a history of criminal legal involvement. And here in California, we have many opportunities, and very few barriers. So really kind of the time is now to do this work. And so to kind of leave you with a quote from one of our patients, he says, "The transitions clinic staff don't judge you. They treat you like a human being, like you're still a person. That's something that prison takes away from you. And when you get out, society takes that away from you too." And I think that's what makes the transitions clinic so successful. So we have a very short 2-minute video that we wanted to share with you all, which really kind of talks about this from the perspective of our community health workers nationally. This is a video from our last in-person convening where health systems and community health workers come together to work on improving healthcare for communities impacted by mass incarceration.
For me, spending 27 years in prison and understand, know what I went through in my life overall, it's like we're continuously having to prove ourselves. I just got out 2012, and the work that I was able to get was as a result of TCN.
I had been out since 1999. I wasn't looking to be a community health care worker. When she created the transition clinic, she provided a person like me with a job.
When I looked at the job description, it said you had to be formerly incarcerated. I'm like, dang, where? I gotta be formerly incarcerated? Wow.
With all the community health workers having that history of incarceration, it brings a realness to the table that all our clients really recognize and gravitate towards. When you're dealing with someone that has been where you have been, you are more prone to trust what they're telling you and trust the direction they're trying to lead you in, especially when you look at someone that was coming from incarceration and now has a government job, works for the government. You know, that screams volumes.
When I got out of prison 3 years ago, I never thought that I would have this kind of a job. It was cool to be able to get a paycheck and be seen as somebody, not just a number, but who can work and be successful and then help other people coming out.
We all got records. We have lived experience. And it's something about having that lived experience that you give the next person hope. I said, we got our own clinic, y'all. And when I say that, you know, they laugh, and it makes them feel good. I'm a part of something. Even though I'm formerly incarcerated, just being able to be a part of this here, you know, and then to get others to come and be a part of this here, it's golden.
So, you know, with that, I think we can kind of wrap up and take questions. I did see one of the questions was specifically about how do we recruit people? How do they know about open jobs? Joe, you want to speak to that a little bit more?
You know, I have a, we use a lot of different ways. One of the ways is the relationships that I've developed over the years with parole, probation, but more importantly, the community that I serve, you know, prison. So, you know, a lot of the time, you know, I have friends from Eureka to San Diego that I've kept in contact with, long-term offenders who I've watched over the years work with EOPs and different populations and seen the changes, and wanting to have them be a part of this incredible work. Thus far, when I'm doing some type of talent finding, those are the same people I use. So then I reach back out to them, and we all know in those circles, you know, who's bringing what to the table and why. And it's been incredible to be a part of that process and to be a part of the interviews and to interview others. There's certain things I'm looking for and others I'm not. And, you know, there's some things that could be taught, some things that can't. So that's another thing that, you know, over the years doing this type of hiring of who I'm looking for, you know, really centers around passion, centers around what they've been up to for the last year or two, centers around, you know, what they're doing today, not what they did 20 or 25 years ago.
Thanks, Joe. And I just see a comment here from Erica Morse, who's one of our leads at Lifelong. And she says, as a TCN participant and supervisor of a person that's formerly incarcerated and intentionally recruited that way, I just want to share that the trust our patients have in this employee and her ability to connect with anyone, anywhere is invaluable. Joe helped me hire her, and I'm so grateful for his support, her work, and all the CHWs and what they contribute. They're the heart of why this works. Thanks for saying that, Erica. And I wanted to read that because I did want to also just say, you know, we do train health systems in doing this work. And so I just want to offer, you know, we're available for people who are interested. And in fact, coming up this year in January, we are going to have a new cohort of clinics in the Central Valley and Inland Empire. So if there's any of our UCSF partners from that area, you know, we are going to have some targeted training around that time, but anyone else who's interested in this work, we're always happy to have a conversation or start the conversation. Thank you, Erin. And so Erin also says that I worked in the same clinic as Dr. Shabib Joe and the transitions team many years ago. I can't tell you how impactful the work is and what they're doing. I'm in awe and so grateful. Well, I'm grateful. Thank you guys for these wonderful comments. This is really nice. And then it looks like there might be another a comment. Thank you from Wiley. Yes, UCSF is an anchor institution, and I would love to talk with you more about these opportunities to think about more broadly how health systems can kind of try to dismantle this system that is structurally racist and really prevents people from gainful employment and has significant impact across families and communities.
And, you know, I want to give a real quick shout out to Roberto Vargas too, because, you know, we grew up in the same community. And, you know, there's been times that I'm out doing outreach in my community and I see him walking like the doctors from General through the community and kind of like giving them a community breakdown and a feel about where we come from. And I remember running across him one day and just having a conversation with those new doctors. And just, you know, that's what we need. We need to look at old problems, but come up with new solutions that are community-based. Thank you.
Shira and Joe, I just want to thank you both for an incredibly impactful, thought-provoking discussion that's hopefully only the beginning of our engagement with this really important topic. For some of us, some of us have been doing this work for years. Some of us are just getting started. As a reminder, for those of you who are residents right here, you will soon be in the position to advocate for who is hired and how they're hired. And this is important work for all of us who take care of patients, who are part of the healthcare system, and just who are humans in the society. So thank you for giving us so much to think about. I really appreciate it. And I appreciate your hard work that's gone into the years of experience and thoughtful work to really help move the system and make a difference. I want to give you the opportunity to have the last final words here. Just with a reminder to everybody who joined us late, if you missed part of the presentation and you want to hear it, it will all be uploaded onto the website. You can watch it on YouTube, or if you've missed any other grand rounds, please fill out an evaluation also of the session today. We can give our presenters feedback. Thank you to everyone who joined us. And again, I want to give Joe and Shira, I'm going to give you the last word here, because really all I can do is express my deep appreciation. So thank you.
Thank you. And I want to express my deep appreciation for you and for this forum to share our work, especially with all of our colleagues. You know, I've always been so impressed, you know, in particular as of late, all of the anti-racist initiatives that our department is engaging in. And just want to encourage people to think of this as one more systematic approach to trying to dismantle the harms of mass incarceration on communities, particularly Black and Brown communities. And so thank you so much for giving us this opportunity to share. And I know Joe wants to wrap it up.
I also want to thank you for providing me a seat at the table. You know, one of the ways out of this is to bring the community to the table when we're thinking about policies, jobs, and everything else that's going on. But I think for a last word, I just want to challenge everyone that's on this Zoom to walk away from here today challenging a stereotype, thinking about, you know, doing your own implicit bias test and just challenging a stereotype today. You know, if you don't know by now what the media feeds you, it's all angled. You know, violent offender versus nonviolent offender. That's it's untruth. You know, we come home after long sentences to be a part of the solution. Stop talking about change and be the change that you want to see wherever you're at. Thank you.
Thank you. And thank everyone for joining us.